Good afternoon, everybody, and welcome to this ERKNet webinar. My name is Elena Levtchenko, and I am speaking from my office in Amsterdam. Before starting, let me remind you that your microphones are turned off, but during and after the webinar, you can send your questions through the GoToWebinar application that appears on your screen. I will ask your questions at the end of the presentation. The webinar will last approximately 30 minutes, and we will have about 15 minutes available for questions. As usual, this webinar will be recorded, so you can watch it again on the ERKNet platform. Let me announce our speaker of today. This is Dr. Agnieszka Prytula from Ghent University Hospital in Belgium. Dr. Prytula completed her general pediatrics training at the University of Antwerp and the subspecialist training in the pediatric nephrology at the Great Ormond Street Hospital in London and the Erasmus Medical Center Sophia Children's Hospital in Rotterdam. Upon her return to Belgium, she has taken the position of a staff member at the Nephrology and Rheumatology Department at Ghent University Hospital, and she is also affiliated with the Department of Internal Medicine and Pediatrics at the Faculty of Medicine and Health Sciences at Ghent University, where she conducts her research and teaching. Agnieszka, the main focus of her research and clinical interest lies in the pediatric kidney transplantation, the clinical aspects and the use of immunosuppression after solid organ transplantation, and especially the topic of the webinar today, which is mineral bone disorders after kidney transplantation. So Agnieszka, I think it's enough of the introduction. The floor is yours, and good luck to everybody. Please ask questions and be active.
Thank you very much, Elena, for this kind introduction. I'm sorry you can't see me, but I have some technical problems with my video, but it shouldn't matter because we will start with a presentation. Can you see my slides?
Yes, we can see the slides. All works.
So, good afternoon. So I'm going to talk to you today about chronic kidney disease, mineral and bone disorder after kidney transplantation. And after a brief introduction, I'm going to give you some information on the evaluation of post-transplant CKD-MBD. Then I'm going to talk about the management of post-transplant CKD-MBD. I'm going to show you the main results of the studies we've done together with a certain registry. These were collaborative studies with the ESPN transplantation and CKD-MBD working groups and the certain registry. And I'm also going to mention the European clinical practice recommendations for CKD-MBD after pediatric kidney transplantation that are being developed right now. The clinical picture of post-transplant CKD-MBD is broad, and it includes skeletal deformities, bone pain, fractures, growth failure, and vascular and ectopic calcifications. And the earliest alteration in the pathogenesis of CKD-MBD is elevated fibroblast growth factor 23, FGF23, that binds to its co-receptor klotho, leading to phosphaturia. And it also decreases calcitriol synthesis. And also one of the actions independent of klotho is myocardial hypertrophy. So when we look on the right-hand side and the evolution of biochemical abnormalities in the pathogenesis of pre-transplant CKD-MBD, then we first see the uremic toxins, then FGF23 that starts rising early in the course of CKD from stage 2-3 onwards, then PTH, and lastly phosphates. The three major contributing factors to post-transplant CKD-MBD are the pre-existing CKD-MBD, the use or the side effects of immunosuppression, and the graft function. And it is also important to say that prior to transplantation and starting from the early stages of CKD, all efforts should be made to optimize bone health but severe pre-transplant CKD-MBD should not be regarded a contraindication or a reason to delay or withhold transplantation. So at time of kidney transplantation, most patients have elevated FGF23 and elevated PTH. And then we have the recovery phase. And during the recovery phase, FGF23 and PTH are usually still elevated. And in the presence of largely restored kidney function, it leads to hypophosphatemia. And then we have the period where all parameters of CKD-MBD are supposed to be normal. And then with gradually impaired graft function, we get the whole cycle again with elevation of FGF23, hyperparathyroidism, and hyperphosphatemia. Also, during the recover phase, we often encounter hypomagnesemia, a side effect of tacrolimus use. Well, when we compare the median PTH levels in pre and post-transplant children with CKD, then we see that children with that pre-transplant children with CKD with corresponding GFR tend to have lower median PTH levels than post-transplant children. So let's take as an example stage 3A with GFR between 45 and 59 mils per minute. Pre-transplant median intact PTH is 48 picogram per milliliter, whereas the reported PTH in post-transplant children is 62 picogram per milliliter. And in the brackets, you see the interquartile ranges. And this is a slide from one of the certain registry studies. We see that when we look at parathyroid hormone, PTH, so that's the left column, we see that indeed the proportion of children with hyperparathyroidism is getting lower and lower up until approximately 1 year post-transplant, and then it stays stable, and the proportion of children with high PTH is between 35 and 43% from 1 year onwards. Also interesting, hypophosphatemia in 36% of children, so that's the right column, and 36% of children at 1 month post-transplant. So I showed you that we have a period of normal CKD-MBD parameters, but actually it doesn't always hold true, as significant proportion of patients have hyperparathyroidism. And the risk factors for persistent post-transplant hyperparathyroidism are older age at transplantation, longer dialysis vintage, deceased donor kidney transplantation, high body mass index, pre-transplant hyperparathyroidism, and nutritional vitamin D deficiency or insufficiency. So let's get to the evaluation of post-transplant CKD-MBD. Of course, very important is the clinical evaluation with history when we asked for bone pain and fractures, and then clinical examination with measuring of height or length in young children, weight, and we look for skeletal deformities. The laboratory evaluation I'm going to discuss on the next slide, and then the imaging. Actually, X-rays are the only form of imaging that is routinely recommended, and also only if the results are expected to impact on treatment decisions. So we shouldn't do any imaging actually routinely in all patients, only X-rays if we really think that it would change our clinical approach. Other examinations such as DEXA scans or PQCT or high-resolution PQCT or magnetic resonance or ultrasound should only be considered in exceptional clinical cases and for research questions. And I also wanted to say a few sentences about bone biopsy. Bone biopsy has long been regarded as the golden standard in the evaluation of CKD-MBD, whether pre or post-transplant, whereas actually there are only very few specialized centers worldwide where the evaluation and interpretation of bone biopsy can be performed. So that's why bone biopsies should be considered only in pediatric transplant recipients in rare selected cases if the clinical and biochemical findings do not explain underlying bone disease. For instance, in severe bone deformities or severe pain, low energy fractures, persistent hypercalcemia or hypophosphatemia despite optimizing treatments. And it is also important, if you do perform bone biopsy, that the evaluation and interpretation should be performed in centers with sufficient expertise. Then the laboratory assessment of CKD-MBD. The parameters that we routinely measure in transplanted children are vitamin D, calcium, phosphate, bicarbonate, PTH, alkaline phosphatase, and magnesium. And the frequency is dependent on the severity of CKD-MBD, on the allograft function, time since transplantation. But actually, in all these parameters, the most important thing is that we should not look at single values, but we should actually look at all these parameters taken all together and also at trends rather than single time point values. The management of post-transplant CKD-MBD. Well, the role of nutrition and vitamin D, either native or active analogs of vitamin D, is actually not debated. So the clinical practice recommendations should be followed for native and active vitamin D analogs for children with CKD, whether pre or post-transplant. These are actually the same recommendations that can be applied to post-transplant children as well. And then calcimimetics may be considered. Important to know that they are off-label. Calcimimetics in Europe are only approved for use in dialysis patients, but these are actually valuable drugs, allosteric modulators of the calcium sensing receptor in parathyroid, thereby decreasing PTH release. And they may be used in refractory hyperparathyroidism with hypercalcemia. Antiresorptive agents, I put this even in a smaller font because they are really used only in exceptional cases. So bisphosphonates or antiresorptive agents, bisphosphonates, they inhibit osteoclastic bone resorption. They are definitely not recommended for routine use in children after kidney transplantation, but may be considered in the presence of severe hypercalcemia that persists despite stopping all sources of calcium and vitamin D. And then there are two clinical questions or clinical dilemmas that I highlighted in blue. The treatment of mild and moderate metabolic acidosis. There is actually an ongoing debate in adults with pre and post-transplant CKD and also in children. We actually do not have high quality data indicating whether we should or should not treat mild to moderate metabolic acidosis. Well, we actually don't have data indicating the benefits of treatment of mild and moderate metabolic acidosis. And I'm going to show you some pediatric data from our certain registry studies in a few minutes. And there's also the dilemma of whether to treat or not early hypophosphatemia and hypomagnesemia. In theory, both hypophosphatemia, hypomagnesemia may cause bone demineralization, but we have no evidence that treatment would result in improved patient outcomes. So we know that phosphate and magnesium supplements may have gastrointestinal side effects, and this decision whether to treat or not should be balanced against the risk of side effects and the medication burden that your patient is going to tolerate. Because if there are too many medications, then the patients might decide or might actually get tired of taking all kinds of drugs, and they may also it may also result in non-adherence to immunosuppression and allograft rejection. But why should we actually measure all these CKD-MBD parameters? What would be of importance is knowing whether the arrangements in calcium, phosphate, PTH, vitamin D, magnesium, metabolic acidosis, or alkaline phosphatase, whether they actually result in poorer clinical outcomes, such as allograft dysfunction, such as sexual growth delay, bone deformities or fractures, or cardiovascular morbidity and mortality. But it is actually very difficult to design pediatric studies on post-transplant CKD-MBD with relation to patient or allograft outcomes. And the reasons for that are multiple. I just listed here a few of them. Firstly, the low patient number. Less than 5% of all transplanted kidneys in the Eurotransplant area in 2019, so it was pre-COVID, pre-pandemic year. So less than 5% of all transplanted kidneys went to pediatric recipients. There's also paucity of good outcome parameters that we may use, as allograft loss or death are much less frequent in adult than in pediatric than in adult kidney transplant recipients. And lastly, it is very difficult to show the causality, because we know that lower EGFR results in derangements in CKD-MBD parameters. But is it also the other way around? Is it also that deranged CKD-MBD parameters result in EGFR decline? And as I mentioned at the beginning, with transplantation and CKD-MBD working groups of ESPN and a certain registry, we looked at registry data with respect to calcium, phosphate, PTH, and vitamin D. And we analyzed whether derangements in these parameters would result in allograft dysfunction. And this study was published beginning of 2023. We included 1,218 patients with 1,218 grafts. It was 1 graft per patient. 1,134 patients with the first graft. Patients came from 40 centers across 16 European countries. And we performed a survival analysis with time to composite endpoint. And the composite endpoint was defined as either graft loss or EGFR lower than 30 mils per minute per 1.73 meters squared, or 50% decrease from baseline EGFR at 4 weeks. As we know, EGFR decline of over 30% between years 1 and 3 is associated with heart outcomes after kidney transplantation. And when we look at the relationship between hyperparathyroidism and allograft outcome, then we see, when we first look at the left figure, then we see that patients with hyperparathyroidism, that's the petrol blue line, that these patients had a higher risk of reaching the endpoint, the composite endpoint. And the right-hand figure shows that the higher the PTH expressed as ratio above upper normal limit, so the higher the PTH ratio, the higher risk of reaching allograft endpoint. And these figures show the unadjusted analyses, but it was also confirmed in multivariable analysis. So the association between hyperparathyroidism and allograft outcome. We looked at the association between low vitamin D and allograft outcome, but in this study we didn't find any. But we know that low vitamin D is widely prevalent in pediatric kidney transplant recipients. And we know that low vitamin D levels are associated with high PTH. They may be associated with short stature, and this comes from previous studies. We also looked at the association between hypocalcemia and the composite endpoint. It was significant in the unadjusted analysis, the same for hyperphosphatemia and the composite endpoint, but these analyses were no longer significant and multivariable after adjustment for covariates. We also looked at the association between metabolic acidosis and allograft dysfunction, and this was published earlier this year. But before I show you our results, I wanted to briefly discuss this study in adults that was published in Lancet, I think in 2023, quite recently. And it was actually a single-blind placebo-controlled trial where 108 adult kidney transplant recipients were treated with alkali, whereas 98 adult kidney transplant recipients with metabolic acidosis were not treated. And but both groups, patients in both groups had actually quite mild metabolic acidosis with 21.3 median bicarbonate level or 21 millimole per liter bicarbonate level in the placebo group. And actually the conclusion of the study was that there was no difference in the rate of the decline in estimated GFR in patients who were treated with alkali. And the conclusion was that the treatment with sodium bicarbonate should not be generally recommended to preserved eGFR in kidney transplant recipients with metabolic acidosis. So this was done in adults, but we still felt that we need pediatric studies, as pediatric patients have other primary kidney diseases, they have other comorbidities, they have different diets, they still have to grow, and we also found that young age is a risk factor for metabolic acidosis. And we found indeed an association between metabolic acidosis and composite endpoint, so allograft dysfunction. And as you see on the right-hand side, the lower the bicarbonates, the higher the risk of reaching the composite endpoint. And we also looked what happens after correction of metabolic acidosis. And here we had 4 groups in this analysis. The green line represents patients with no metabolic acidosis and no alkali supplementation. And they had the best outcome. And then we have a group of patients with corrected metabolic acidosis with alkali. Then we have a group of patients with no alkali and also metabolic acidosis. And the last, the red group, the red line represents a group of patients with metabolic acidosis under alkali. So those who had insufficient control of metabolic acidosis. And the last group had the worst outcome, whereas the group of children with no metabolic acidosis, no alkali, had the best outcome. And there was actually no difference between the group of patients with controlled metabolic acidosis under alkali and those with metabolic acidosis and no alkali. And then very recently, we also looked at the association between, well, I'm sorry, it's not alkaline phosphatase, it's metabolic acidosis and growth. This study is still under revision. So we looked at factors associated with statural growth in pediatric kidney transplant recipients with a focus on metabolic acidosis. And these are the results of, of the analysis of generalized additive mixed models on factors associated with statural growth. And we see that all the well-known factors associated with statural growth were significant, with glucocorticoid use, recombinant growth hormone, glomerulopathy as a primary kidney disease, but plasma bicarbonate was not associated with statural growth. And this you can see here in this figure on the left-hand side. The vertical stripes on the x-axis represent the real-world bicarbonate values. And we see that actually in this analysis, the lower the bicarbonate value, the higher statural growth. It was expressed as the difference in Z scores between two consecutive visits. And then on the right-hand side, I just gave you some examples of analysis, significant analysis. So, for instance, here, the relationship between higher eGFR and better statural growth. So conclusions of the studies are that post-transplant CKD-MBD is highly prevalent, even in children with a good allograft function, that there is an association between hyperparathyroidism and poor allograft outcome. There's also an association between metabolic acidosis and poor allograft outcome. We found no association between metabolic acidosis and growth. And also 42% of patients had incomplete resolution of metabolic acidosis under alkali supplementation. So what this could actually mean is that these patients need personalized therapy different than alkali supplementation. It could be that they have different type of metabolic acidosis. For instance, type 4 metabolic acidosis is a known side effect of tacrolimus use. And maybe these patients need other therapies than simply alkali. And I also wanted to let you know that as per initiative of ESPN transplantation, CKD-MBD, and dialysis working groups, we are preparing clinical practice recommendations for evaluation and management of CKD-MBD post pediatric kidney transplantation. We had a meeting in July earlier this year in Ghent, where we discussed these recommendations, and the manuscript is currently under preparation. I'm not going to give you details on this clinical practice points because we still have to fine-tune them, but we have 5 main topics. or PICO questions, being the assessment of management of CKD-MBD prior to transplantation, assessment and management of early CKD-MBD early after transplantation in the first 3 months, assessment and management of CKD-MBD after transplantation beyond 3 months post-transplant, and also the impact of steroid minimization or withdrawal on growth and bone health. And this was our timeline. So far, so good. We're actually, everything is going according to this scheme. So we hope to be able to initiate the Delphi rounds, well, probably beginning of 2025. And to conclude, I have some suggestions for future research questions with regard to CKD-MBD after pediatric kidney transplantation. Well, we don't know whether we have to treat early hypophosphatemia. Do we have to treat hypomagnesemia post-transplant? What is the optimal PTH target based on patient and allograft outcomes? Do we have to treat especially mild and moderate metabolic acidosis? And do we have to differentiate between various types of metabolic acidosis and go for personalized treatments? But anyhow, answering all these research questions would require collaborative efforts. So I hope to work with you in the future on this. And I would like to conclude and thank you for your attention and happy to take questions.
Thank you very much, Agnieszka. This is a wonderful webinar. It's a pity we cannot see you, so that attendees can only enjoy me on the screen, which is a pity, of course, because you are much more beautiful. But anyway, I think we have some questions. I will open the question poll. Maybe while people are thinking about the questions, the questions start to appear, so I will wait with my own questions and just read the questions that people are asking. So Dr. Anna Dovk is asking, how do you currently treat significant hypophosphatemia, for example, with very low levels below 0.4? She gives some examples immediately after transplantation. Do you think that is an indication for phosphate supplementation or for the cinacalcet?
Well, I think that I can speak of common practice, actually, things that we discussed during our clinical practice recommendations meeting in Ghent. Most centers would prescribe phosphate supplements in severe hypophosphatemia, and definitely 0.4 mils per liter qualifies as severe hypophosphatemia. And most centers would prescribe phosphate supplements then in severe or refractory hypophosphatemia.
Mm-hmm. Yeah, and maybe you discussed it, you told that it's not known yet, but what do you think is the level? Because I think most people don't supplement phosphate after kidney transplantation, just wait or maybe adjust the diet because you can enrich phosphate in the diet. So what is a low level of phosphate when you would think the phosphate should be supplemented? Maybe, yeah. Yeah.
Well, I don't think that there's a uniform cut point. I would think definitely under 0.5 millimoles per liter.
Okay. Mm-hmm. Yeah, so yeah, that's what you are doing in your routine clinical practice.
Yeah.
Okay.
Yeah.
Okay. So in adult patients, another question. In adult transplant patients, many centers routinely perform bone densitometry post-transplant, and it frequently shows osteoporosis. Mm-hmm. So the question is whether it will be appropriate to initiate antiresorptive treatment or weight and follow-up. So it's more a question, I think, from the adult nephrologist, but you maybe can comment on that.
Well, we also discussed the utility or the clinical application of routine DEXA scans. And actually, I think that we all agreed that routine DEXA scans in children should not be performed, whether pre or post-transplant. I think it may also be different in adults. I'm not going to give recommendations on the management of CKD-MBD after transplantation in adult kidney transplant recipients. It's different. I can also say that antiresorptive agents, bisphosphonates, are actually used only in exceptional cases in pediatric patients. And I would definitely not recommend on the routine or on the routine use of bisphosphonates. I think in children with refractory hyperparathyroidism with hypercalcemia, I would go for calcimimetics rather than bisphosphonates.
Yeah, I think in general, adult colleagues more frequently use DEXA scans. They have also more maybe validated reference values. So it's always a discussion. I remember the discussion about DEXA we had when we have written the distal RTA guideline. It was really, a big discrepancy between pediatric and adult physicians. So maybe you can speculate about the mechanism, how elevated PTH can make the graft outcome more severe. And it's a little bit the chicken and the egg question, maybe. How sure can we be that it's not the initial graft dysfunction which leads to the elevated PTA levels in this multivariate analysis?
Yeah, actually, what we did in our study, I didn't include it in the presentation today, but we did in our study, we applied structural marginal models in an attempt to estimate the causal effect of PTH on allograft function. And this association between hyperparathyroidism and allograft dysfunction was also confirmed in these structural marginal models. We looked for possible explanations in the literature. We looked for possible explanations for this association. And what we found was the fibrosis, that hyperparathyroidism is associated with kidney fibrosis, which may contribute to faster allograft function decline. But also this would have to be confirmed in prospective studies, which would be, of course, difficult to design given the low number of patients we have.
Right. So another question here is, so somehow surprising, no association with acidosis and growth parameters. Find it surprising, or do you have a comment on that?
I find it personally, I find it disappointing, maybe not surprising, but I find it disappointing. It's, of course, but I think one of the possible explanations is that steroids, some corticosteroids that are frequently used after transplantation, they also, to some extent, have mineralocorticoid effects. And as we know, the use of glucocorticoids is actually the strongest factor associated with growth stunting. And I think it may be the reason why we didn't find the association between metabolic acidosis and growth stunting.
Yeah. Okay. I'm checking for more questions. I don't see them. So I think before closing the webinar, I would like to thank you very much for the wonderful lecture. Once again, please send the information about this webinar to your colleagues. It is recorded and you can watch it again. And I would like to announce our next webinars. Please register for them. So the next webinar will be on December 17, and the lecture will be given by Marina Vivarelli from Rome on the IPNA guidelines on IgA nephropathy. And the first two lectures in 2025 will be on January 14, non-cystinosis Fanconi syndrome. I discovered that I'm going to give this lecture. Good to know. And on January 28, the lecture will be given by Nicole van de Kar from Nijmegen on the Streptococcus pneumonia HUS. So please register to this webinar. And once again, Agnieszka, thank you so much for the wonderful lecture, and thank you all attendees for your kind attention. The webinar will be closed.
Thank you.
Thank you. Bye.
Bye.
Thank you. Bye.
Bye.
Bye.